Welcome to another Persiska tumor board. We've got a great number of cases to discuss today, a lot of interesting and challenging cases. Before we get started, I would just like to go around the chat room here and introduce anyone. I'm Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine, and I'm joined today by a wonderful faculty, multidisciplinary faculty. I'll start with Dr. Kamage. Dr. Kamage.
Hi, I'm Ross Kamage. I'm a medical oncologist. I'm the director of thoracic oncology at the University of Colorado.
Great. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging and the vice chair for education at Memorial Sloan Kettering Cancer Center, and also professor of radiology at Weill Cornell Medical College.
Great. Dr. Force.
Hi, I'm Seth Force. I'm the chief of thoracic surgery at Emory University Hospital in Atlanta, Georgia.
And last but not least, Dr. Curran.
Hi, Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and adjunct professor at Emory University.
Great. Welcome, everyone. Pleasure to have you all here. This is a 53-year-old male from Jamaica, never smoker, newly diagnosed oligometastatic adenocarcinoma of the left lung with an isolated 3-millimeter focus in the brain. We'll talk about this. He has a 4.5 centimeter left lower lobe mass and hilar and mediastinal adenopathy. His stage is the T2B-N2M1. We'll talk a little bit about how the ALK rearrangement or ALK alteration was detected. The questions being asked here are, can curative intent therapy be pursued with this oligometastatic focus? And if the patient becomes metastatic, does the fact that the patient has an ALK rearrangement noted on FISH but negative on NGS affect management? And then does the patient's BRAF mutation, which is a non-B600E, does that play in at all? And is this something that is actionable? So that's a brief summary. So patient presentation, the patient presented with a hypertensive emergency and elevated troponins. His additional symptoms included cough, hemoptysis, fatigue, and malaise. He has a preserved performance status ECOG-1. His past medical history is consistent with hypertension, diabetes, a previous stroke with stable residual right lower extremity motor deficit requiring use of a cane. He has some CKD, his baseline creatinine is 1.3, but does have frequent episodes of acute kidney injury. His social history is a never smoker, no alcohol or drugs, and family history is consistent with a father who had lung cancer who was also a never smoker. Due to his presentation of cough and hemoptysis, he does get a CAT scan, and I'll let Dr. Ginsberg take it away here with the evaluation of what we see here.
On this axial CT image, we see a 4.5 by 3 centimeter left lower lobe mass. And on this study, we did not identify any lymphadenopathy or any metastatic disease in the abdomen or pelvis. However, PET CT would be more useful to assess the extent of metastatic disease. And we do see that indeed there is left hilar lymphadenopathy and mediastinal lymphadenopathy in the paraesophageal region, in addition to this left lower lobe mass, which has an SUV of 13.9 and extended medially to the hilar. No other metastatic disease outside of the chest was seen. However, a brain MRI did demonstrate a small 0.3 centimeter metastasis in the anterior left temporal lobe.
Great. Thank you, Dr. Ginsberg. So in summary, a left lower lobe mass, 4.5 centimeters, it's SUV of 13.9, so it's FDG avid. CT scan doesn't show adenopathy, but the PET scan does reveal some adenopathy, and as Dr. Ginsberg mentions, an isolated 0.3 centimeter focus on the brain MRI that we don't have images for. So the patient gets a EBUS biopsy of the lung mass that reveals a poorly differentiated adenocarcinoma consistent with lung. He does have a mediastinal lymph node interrogated that's positive for carcinoma. It is TTF1, napsin A, and P40 positive, so a mixture here of different histologies, at least based on IHC. So the patient gets several different platforms done on his tumor, and I'll perhaps after reviewing this, call on my oncology colleague to perhaps layer in some insight on this, but the IHC for the tumor is weakly positive for ALK. The FISH is also ALK positive. It had an ALK rearrangement is identified. But the next generation sequencing, and we don't have a lot of information on what next generation sequencing was used, but interestingly enough, does not confirm the ALK fusion. It's not noted on NGS, but it does have a point mutation, a non-V600E BRAF mutation, and the PDL1 is 0. So a lot to unpack here. Dr. Kamich, I'll turn to you first. What do you make of this discrepancy between the IHC, FISH, and next generation sequencing reports, given your global lead in a lot of the ALK trials? Can you shed some insight on this? And this is something that you see in your practice.
So thanks, Dr. Levy. So yes, absolutely. I mean, this is kind of more information than you would want because it's giving you conflicting information. On the one hand, we know that some of the earlier diagnostic tests, immunohistochemistry, fluorescence in situ hybridization, can have both false positives and false negatives more than next generation sequencing. And so you're tempted to kind of give priority to the next generation sequencing data, but you said something very important. It's not just what was the panel that was done for next generation sequencing. I want to know if this was based on blood or tissue. So if it was based on blood, I would actually deprioritize the next generation sequencing and prioritize the fact that we have a FISH test and an immunohistochemistry test pointing in the direction of ALK. If this was tissue, however, I would prioritize the next generation sequencing and say it's much more likely that this is a true class 3 BRAF mutation, which is not currently actionable, and therefore they're not going to be responding to an ALK inhibitor.
Dr. Kamich, would it matter if I said that the tissue NGS wasn't an RNA-based platform, it was a DNA platform? Would that sway you? Maybe the DNA-based platform can miss these fusions, and what we see with IHC and FISH was real, but the NGS in this case was not real? Is that possible?
Well, you introduce a whole nother level of complexity. So yeah, when you're doing a next generation sequencing panel, the starting material can be the DNA or it can be the RNA, which is then converted to cDNA. Now, the only value of an RNA-based extraction to throw into the mix is it helps you find fusions where you don't know the 5' fusion partner. So you can just go from ALK into unknown much more simply if it's an RNA-based panel, or for some of the things like MET exon 14 skip mutations, which we know it's much more sensitive for. In general, something like 90+% of ALK rearrangements in lung are EML4 ALK, which should be picked up with a DNA-based panel. So yeah, you would introduce a slight complexity there, but honestly, that's going to be pretty small print.
Got it. And so based on what you're seeing here, let's say that, and we're going to make the assumption that this patient is ALK, but assuming what you see here, Dr. Kamich, are you confident that this is ALK? Or if this is tissue NGS, would you say, look, the IHC and FISH are false positives here, and this is unlikely to harbor, the tumor is unlikely to harbor an ALK rearrangement?
I think if this is tissue next generation sequencing, I would say they're likely to have a non-V600E BRAF mutation as their driver, and the other stuff is falsely misleading us. Now, we're going to get into how do we treat this patient, but of course, we could actually do the experiment in the patient. We could put them on an ALK inhibitor and see if they responded, and probably nothing bad would happen during that period of time. But I think Dr. Curran may nudge me to be sort of more aggressive about actually dealing with the elephant in the room, which is trying to cure the patient.
So let's move forward. We're going to make the assumption in this case, for now, that this patient has an ALK rearrangement, despite what we're seeing here. Maybe we can mix up the scenario at the very end, but let's get to the questions, Dr. Kamich, that you have already sort of asked here. And this is, again, coming to fold in a lot of the literature recently. Can we deploy a curative intent therapy for single brain metastases? Dr. Curran, this patient has oligometastatic disease. Your potential management of the 3 millimeter, 0.3 centimeter left temporal lobe lesion in this case?
So the first thing I'd say, Dr. Levy, is to really be certain with my neuroradiology colleagues that this is unequivocally has the imaging appearance of a brain met. When you have a single lesion in that's only 3 millimeters, I would want to have full confidence. And if that involves some new sequencing or high resolution MRI or spectroscopy, probably won't help, then I'd want to do that. If we are 98% sure it's a brain met. 3 millimeter asymptomatic lesion in the temporal lobe, which is a little more probably able to manage a little bit of growth. I do not feel there's an immediate need to apply stereotactic radiosurgery. I think the real broad question is, do we go with a multimodality approach broadly for his intrathoracic disease, or do we think about an ALK inhibitor first, followed by multimodality therapy? There is no one pathway here.
Yeah, you may, go ahead.
If we believe he has significant symptoms and we feel the value of thoracic radiation with chemo is needs to be done quickly, that's one approach. I think one thing to consider would be an ALK inhibitor for a couple of months, review the MRI of the brain, look at the lung response,